A mature intumescent cataract, rhexis runaway, and recovery. This is today we'll see. And we'll also appreciate that how a capsular rhexis forceps is so useful in managing this situation. So this is the nearly hypermature kind of cataract with pearly white color with which the patient presented for surgery, and as usual when the fundus is not visible, a B scan is mandatory, and this is the B scan which shows a normal posterior segment, and we can see that the incision has been made and the capsule has been stained with the trypan blue dye. Now using a forceps to create a flap and then propagating the rhexis using the same flap, and mind it, this is being done with the left hand, which is my non-dominant hand, and we will see carefully the rhexis being propagated, and because it is my left hand, so I take a little more time than usual and watch how this happens. Now we can see the rhexis is slightly spiraling out, and this has been recognized, and so the viscoelastic gel has been replenished in the anterior chamber, which is the first step to do when the rhexis is spiraling out. Now again, because the time taken is too much, so that allows the leakage of viscoelastic from the anterior chamber, and now we can see that the rhexis has really run out. And this is the point and the utility of rhexis forceps, which can bring it back into its position so that the rhexis is, although not congruent and circular, but it is still intact. So going ahead, grabbing the flap and then pulling it back into its track, so we have a little eccentric rhexis, but it is still complete. So now proceeding for rest of the surgery. Hydrodissection is not needed in these cataracts where it is already a liquefied cortex, so we directly proceed for a direct chop, direct horizontal chop. Now issue with these kind of cataracts is that because the intralenticular pressure is on a higher side, so it's like a balloon which is ready to burst. So when you just simply put a pin on a balloon which is stretched, it simply bursts with the size of the opening, which is much larger than the pin head or pin tip. So here also, when the capsule is opened, it simply has a tendency to rip, and the opening which we create can be a rip, just like we see in our Argentina flag sign, where there is a rip in the capsule from one clock hour to the diagonally opposite clock hour, or maybe a situation where you have a rhexis which is simply running out. The good part is that these cataracts, if they are managed well, the patient can appreciate the visual change very well. Aligning the remaining nucleus, which is simply freely floating because there is no cortex or anything which is holding it, and we can see the half of the nucleus is simply floating and not coming to the phaco tip in a proper orientation, so it becomes little tricky. So once we have grabbed the nucleus, we need to chop it into smaller pieces and consume. The last piece should be taken care in a sense that it should be consumed with a lower vacuum, so the foot should be lifted a little bit. The cataract has been removed and there is minimal of cortex left behind, which will remove just in a while. Usually one should take care to clean the cornices of the bag, because there may be some amount of cortex which is left behind, which may pose a situation next day when it comes into the pupillary area after flowing out from the recess where it is simply resting. Implanting a monofocal hydrophilic intraocular lens. The lens is dialed in position and removing the viscoelastic gel. So although these kind of compromises in the rhexis may not look very beautiful in a sense, but they don't compromise the outcome in any way, because if the capsulorhexis is intact and the IOL is placed in the bag, the centration of the IOL is more or less dependent upon the position of the haptics in the bag, which are very much secure. Here we can see there is a hidden piece of nucleus which has been left behind, hiding behind somewhere underneath the iris, and this can be simply pushed into the aspiration port of the irrigation aspiration cannula rather than switching to phaco hand piece. So even this will work. Completing the removal of the viscoelastic and then inflating the chamber, and I can see because it is a little short tunnel, so we need to hydrate it well. If hydration on one side doesn't work, then you can hydrate both the ends of the incision, and usually this will take care. And if it doesn't work, then one has to resort to placing a suture before trying a air bubble. Now this is the post-op day 1 picture, and we can see the outcome is as expected. It is a beautiful outcome with clear cornea centered IOL, and this is the picture at week 1, which again is a nice outcome. Thank you.